We ready to go?
Ready.
Yes, sir.
I don't have to push a button.
Yep.
How they know I need to push a button?
You're up.
Good morning. Morning, everybody. Welcome to IHP. We're going to call this meeting to order. We'll start off with a pledge of allegiance. Please join me.
I'm sorry, can I correct you, Chair? This is IHP Health Access. Thank you.
I just said IHP in generic.
Oh, okay.
Got it.
Ready to begin. I pledge allegiance
To the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
We'll do a roll call, please.
Thank you. We do have a confirmed absence this morning for Supervisor Gutierrez. He's unable to join us. So I will continue. Vice Chair Hagman.
Here.
Supervisor Spiegel.
Here.
Supervisor Armendariz.
Running late, but he'll be here.
Thank you. Member Anderson.
I'm still here.
All right. Member Williams.
Here.
And Member Zorn.
Here.
Thank you. We have a quorum, sir.
Thank you. Any changes to the agenda?
No, sir.
Any public comments on matters on the agenda for IHP Health Access?
No, sir.
Any conflict of interest? Seeing none. We'll entertain a motion for the minutes.
Move.
Second?
We got a motion and a second. All those in favor? Aye. Any opposed? Seeing none. Consent agenda. Dr. John? None?
Policy agenda. There's no items on the consent agenda. There's no
Okay.
business.
Then we'll go to the policy,
Right.
and we'll do our monthly finance report.
Yes, so good morning, members of the board. I will actually not be reviewing this, but just as a reminder, IHP Health Access Enhanced Care Management is comprised of 15 care teams across the Inland Empire. And as a reminder as well, what the Enhanced Care Management team does is provide in-person and telephonic care coordination for vulnerable adults and children. And some of these services include things such as outreach and engagement, assessment and care planning, and health promotion. So what Leona will walk the board through is what the financials have looked like for December 2025. Thank you.
Good morning, Governing Board. For the month of December, we have a surplus. Oh, next slide. For the month of December, we have a surplus of $280K, which brings our year-to-date total of almost $4.7 million in surplus. Although the year was profitable, it was slightly under what we budgeted, primarily due to the ECM team unfilled vacancies. Next slide. This is just a comparison of previous month to December compared to November. So you can see there was a slight decrease in net surplus. Next slide. This is a 3-month trend from October, November, December. You can see each month has a slight decrease. The majority of the decrease in revenue was due to a reversal of some adjustments of outreach that we had to do due to programming logic. Next slide is our balance sheet. Compared November to December, it's still very strong. And our last slide is the cash flow. So we ended the year in December with $7.1 million of cash.
Do you see the trend continuing on this, or you think it's leveling out with the lower amount?
I'm sorry, can you say
The
that?
trend is going down from October to November. Do you see that continue to go down this next year, or do you think it's just leveling out that new level?
I believe it's leveling out. Dr. John, do you have any comments?
Yeah, I think that's what our early observations are as well. Again, this is probably the first full year for which we had information for to kind of track and trend that information. But I know that at this point in time, it feels like a leveling up, but we could definitely track and trend and bring that information back in terms of what we're seeing.
Sounds great. Any other questions from the board on this? Is this an action item or just a receive and file?
Review and file, sir.
Receive and file?
Correct.
Okay. We'll move on. Comments from any the public on matters not on the agenda for IHP Access?
There are none, sir.
Thank you. And any board comments? If not, we'll adjourn the health access to IHP. And if it's okay, we'll substitute the pledge and attendance with the previous one, and we'll call this one to order. Any changes to the agenda for IHP?
No, sir.
Thank you. And we're going to take this a little bit out of order because I know we have some guests. We're going to take public comments on matters on the agenda and not on the agenda.
Thank you, sir. I'd like to call the following. I've got Elijah Linham, followed by Leslie Pachelski, followed by Ms. Rose Pettigrew, followed by Mr. Fernando Abarca. Thank you.
Elijah, who do you play with at We Thrive Therapy?
Rima and Shane.
How did Shane and Rima make you feel?
Happy.
What do you like doing with Mr. Shane?
Doing speech.
What do you like doing with Mrs. Rima?
Playing.
Did Mr. Shane help you talk?
Yes.
Did Mrs. Rima help your hands get stronger?
Yes.
Do you want to keep going to therapies with Mr. Shane and Mrs. Rima?
Yes.
How would you feel if you couldn't see them anymore?
Sad.
Is there anything else you want to say about them? No. I'm here speaking on behalf of my son Elijah. He loves and adores Mr. Shane and Mrs. Rima. They are not just his speech therapists and occupational therapists. They are people who help unlock his voice, his confidence, and his ability to interact with the world. When Elijah first started with them, he did not speak any words. He couldn't grip a crayon. He struggled to communicate even his most basic needs. Through consistency, trust, and their expertise, Elijah has grown in ways that once felt impossible. He still needs support from them, and that support only works because of the relationship and continuity they've built together over time. We're deeply grateful that IEHP approved the out-of-network referrals for We Thrive. Those referrals exist because the reality is that most in-network speech and OT providers locally have wait lists up to 12 months. That is not an option for a child who requires consistent medically necessary care. The problem for Elijah is when IEHP's own system fails at reauthorization time. When letters of agreement are not processed on time, even when providers at We Thrive submit everything required a month in advance, it creates unnecessary and harmful lapses in care. Those lapses don't just affect paperwork, they affect real children. When IEHP drops the ball, it fails me, and more importantly, it fails Elijah. There has to be a better system, one that does not repeatedly put children at risk of losing the very services that allowed them to speak, learn, and grow. I'm asking IEHP to please stop allowing preventable authorization delays to interfere with ongoing care and to ensure continuity of services so children like Elijah are not the ones paying the price for administrative breakdowns.
Say thank you.
Thank you.
Thank you both for your comments.
Hello, Board. My name is Leslie, and I'm here to speak about a serious and ongoing medical transportation failure involving IEHP and its contracted vendors, the most concerning one of all being Call the Car. This incident did not come out of nowhere. Weeks before this traumatic transport, I began emailing you, Mr. McNaughton, because I was witnessing my mother spend an average of 2 hours every single day just trying to secure medical transportation for Fernando's routine medical appointments. Appointments that should have been straightforward were already being canceled or rescheduled because transportation could not be reliably secured. On January 28th, after a traumatic transport incident, I sent a detailed written email outlining exactly what happened and asked very specific questions about safety failures, accountability, and why IEHP continues to contract with this company. As of today, the questions remain unanswered. What makes this especially concerning is that IEHP's website paints a very different picture. On July 2023, IEHP published a press release titled "More Than Just a Ride, IEHP welcomes Call the Car as its transportation broker." That page describes Call the Car as reliable, safe, technologically advanced, and states that IEHP members should never have to worry about missing appointments. That description does not match our lived reality. Fernando had just been discharged from the hospital after a 5-day stay. He and my mom waited nearly 5 hours for the transportation to bring him home from the hospital. He required and deserved safe, professional medical transport. Instead, the transportation team arrived unprepared, could not safely transfer him, could not get him into his bed, and ultimately dropped him. His 78-year-old caregiver here today was forced to physically assist because the transport staff was incapable. This incident was captured all on video. I have that video on my laptop here today to show you all. It was provided to Mr. McNaughton and others immediately after it was finished recording. So this is not new information to IEHP leadership. The video shows lack of training, lack of equipment, lack of urgency. This was not a misunderstanding. It was a failure that directly contradicts IEHP's public claims about this vendor. Fernando deserves a modified vehicle so he can be transported safely, consistently, and with dignity without relying on a system that has repeatedly failed him and traumatized him and his loved ones. My questions today, the same ones sent January 28th, remain. Why did this happen? What corrective action was taken? And why does IEHP continue to publicly promote and contract with a neglectful and incompetent company that has demonstrated it cannot safely transport elderly medically fragile individuals? I will continue to be present here with you all at every meeting to advocate for Fernando until the system stops failing him. Accountability replaces marketing language, and questions are answered directly here in person or in written format. Even today, they are waiting for their ride, who left to take other patients to an appointment. There's no autonomy. They left an hour before we did from the same residence. There's no autonomy with these rides. It's not right, and it's unfair, and you're all going to get to know me pretty well if things don't change. And I would like to show you all this video of them dropping him. They lifted him in a sheet.
That's time, sir.
Yeah, thank you.
And I'd like to show you the sheets that they lifted his body with. There's this. They didn't even put their arms under his body. When the ambulance came to check him out after that, they gave us this. This is what should have been used. This was not used.
Thank you.
They dropped it.
Who's next?
Thank you, IHP.
Good morning.
Good morning.
My name is Rose Pennegill. I'm caregiver to Fernando Abarca. What happened on January 28, 2026, it's unacceptable. Fernando's medical transport was frightening and traumatic. He had just come home from the hospital and was weak and vulnerable. We trusted that IHP and the nursing management would transport him safely. However, it became a nightmare. Despite waiting nearly 5 hours for transport after being told that it would take 1 hour by the case management, we waited 5 hours for transport. After he was discharged, the nurses had already removed all the IVs and all the medical feedings that he had ongoing. We were told by the nurse that the IHP did not give them any info as to who the transporter was, and they didn't have any idea as to who would be picking us up. Actually, him, because I drove my car. And waited 5 hours before they arrived. I left the hospital before so that I could get home to make his bed, other than, waiting for them to be held up. Needless to say, the transport team was not prepared. They did not know how to safely move him. They could not give him safety, and they could not get him safely into his hospital bed. And then they dropped him, hitting him on the doorway and the neck. He's been having migraines and neck pain since. The transport team was very unprofessional. I'm in my late 70s, and I was able to lift him better than what 2 men did going through they couldn't get the gurney into the door, and the ambulance had no problem taking him to the hospital. They allowed 3 dogs out of the bedroom when I asked them not to, because they opened the door to get the gurney into the bedroom, and then they hit him against the doorway. What many people don't see is that this trauma did not start that night. For the prior years before this incident, securing transportation meant spending hours every day that I called for transport, dealing with nonsense. What is the weight? How much what is the height? The address. I mean, come on. This IEP transport needs reform, and big-time reform. Why should an individual that is caring for someone who is needy be, this is ridiculous. I spend too much time dealing on the phone while he needs to go to the bathroom, while he needs to be fed. It's not fair. So at this time, because of this trauma, both before and after the incident, we will continue to advocate for safety for Fernando.
That's time, sir.
Can be transported. Is
Thank
my
you.
time over?
Yes, thank you for your comments.
Okay. So anyway, you get the picture of what we have gone through. half asleep. I woke up at 3 in the morning. Okay, so I'm speaking on behalf of Fernando. He has aphasia. My name is Fernando Abarca. I want you to understand what it feels like to depend on medical transportation and not feel safe even before something goes wrong. I am a 3-stroke survivor. God willing, I'm still here to share my experience before the incident where I was dropped and hit my head against the doorway. My neck and head are very much in pain. I went for an MRI and they could not perform it due to the fact that I could not put my neck back on the table. The therapist and specialist decided that I could not have this test done. The constant stress has made it hard to feel confident that I would get where I needed to get safely, oftentimes witnessing appointments having to be canceled or rescheduled due to unreliability of the system currently in place. The worst happened, I had just been discharged from a 5-day hospital stay at Loma Linda. Case management came to say that at 4 p.m. that we would be picked up in 1 hour. It didn't happen until 9 p.m. 9 p.m. came and we finally got home at 9:30 p.m. where the people who transported me, 2 men, could not lift me safely. Because of everything we've experienced, I will continue to advocate for safe transportation. For me, that means having our existing vehicle modified so I can be transported safely, consistently, and with dignity, without having to rely on medical transportation companies that have repeatedly failed. No one should have to live in this level of fear and trauma just to get to medical appointments. I have watched my devoted caregiver and fierce advocate Rose spend nearly 2 hours a day on the phone just trying to secure transportation for my medical appointments. Too often that uncertainty has led to cancellations or rescheduling my appointments. This should not happen to anyone. The transport has been the worst since we've been getting it. Further, I am unable to ambulate for transfers and I need a Lyft or Hoyer. I've lost weight since my second stroke and doctor has recommended the Flavor Cape shakes. You guys probably know about them. I do not have any, I have lost weight and I can swallow very well, so I do not need the G-tube. I would like to ask for the K-tube.
That's time.
Thank you for your comments, and I think that's all the public comments we have.
Correct.
Okay, just since it's the first time, we can't respond to anything that's not on the agenda, so we could just listen to you, but that's about it we could do, but I'm sure staff is taking notes, and we'll follow that. Thank you for appearing. Yeah. I appreciate it. We'll move on to conflicts of interest disclosures. Anybody have anything on the agenda? Welcome, Jesse. And then, seeing none, we'll move on to election of the chair, governing board. It's that time of year again.
Mr. Chairman, I would like to nominate Supervisor Hagman for this auspicious role.
Thank you. Good. Seeing any opposition? Nope. Thank you very much. You know, I'm
Still
playing.
debating.
I'm playing the role right now. That's why I didn't call on you.
I'm sorry, sir, I didn't catch who
Ms. First,
seconded. Okay, thank you.
All right, the vice chair for Riverside. I'll move Karen.
I'll second.
See, that's why you had to be nice to me. Besides, your partner's not here right now. Any other nominations? If not, all those in favor? Aye.
Aye.
Congratulations, Karen. Okay, now, unless the board wants to pull anything from consent items, we'll take the meeting minutes and the consent agenda. Anybody want to pull anything off? If not, entertain a motion on that.
Motion.
Second?
We got a motion and a second. All those in favor? Aye. Any opposed? Seeing none, we're still not fully awake yet from yesterday, and we'll move on to policy and status reports at agency operations. Start off with our CEO, Jared. Good morning.
Well, good morning, Board. Thank you so much for the time today and for all of your support of our team. We're sure good to be with you today, and we'll make sure that our team follows up with the comments that were made as well today. So we're so grateful and always glad to have our members come and share their experience. We want to know that. So I wanted to just share with you a little bit of a mission moment. This is our 30th anniversary this year. If you did not know, we were founded 30 years ago this year, and we have 4 employees that have actually been with us from the very beginning. And just recently, we had a chance to honor them, and I'm so thrilled, in particular, that Mario and Zuli, that you can see in the picture there, came to our all-employee meeting that we held to just have them share some of the words that they felt that were on their heart from when they started here compared to today. And I'm not going to read through all of these comments that you see here, but I wanted you to just know that we're very fortunate and very grateful that we have employees that started here from the beginning, continue to serve this community, and have such a passion for this sacred work that we provide to the community as well. So a big kudos and a big shout out to them for their continued support. I hope they stick around a little longer. It's always good to have those founding members that are with us, that we call them the originals. All right, moving on, I wanted to share a little bit of our membership report with you. And as you'll see, it's been a bit of a roller coaster here. This was forecasted and expected with what happened on the H.R. 1 front, on the federal side, as well as with the state budget. And while the number there in February that you can see, the actual number, the 1.455 number, contains all 3 lines of business. So this is the Medi-Cal line of business, the D-SNP line of business, as well as Covered California. The interesting thing on that number is next month's report, I think, is going to probably be the most accurate, simply because there is still some what we call effectuation happening within Covered California. And that means that we're still waiting to see how many covered folks that are in Covered California are actually going to pay their premium. And as you might have remembered, part of the challenge on the federal front was the enhanced premium tax credits that have gone away, and that was creating a big challenge for a lot of folks on the affordability. And so right now we're waiting to see where will that end up, and we'll know a lot more here come in just a few weeks on how many of those folks did finally what we call effectuate or pay that premium to actually continue their coverage. So we'll keep you posted on that. This is something that's happening all across the state and all across the country, as you might imagine, with lines of business in Medi-Cal, Medicare, D-SNP, as well as the exchanges that are seeing these kinds of changes here in the membership for plans all across the state and the country. On the next slide, I wanted to share, speaking of our 30th anniversary, this is our 30th anniversary logo. And thanks to Michelle Ryan and their team for pulling this together. You'll see this on all kinds of different collateral, including email signatures and campaigns. And we're just really grateful for the marketing team's work to celebrate this. And we'll have some celebrations throughout the year for our providers and our employee family and our members as well. And we're just really grateful for the years of service that we've had here in this community. On the next slide, I wanted to share with you, we just completed our annual DHCS, or Department of Healthcare Services, medical audit. It was a 2-week audit that covered a time period there that you can see on your screen. They look at all kinds of different systems and processes. They get into charts. They do just a tremendous amount of review on the organization. And I share with folks every time we do these audits that I actually look forward to these, and I really do. I think it's a great learning opportunity for our organization to learn what best practices are happening across the state. And it's great for the state to learn the things that our team is doing that's innovative, that is not being done in the rest of the state. And so we'll share with you more details when this gets wrapped up with a preliminary report of their findings, and then we anticipate in the coming months we'll have their final report as well. But just big kudos to the team for their work on this audit. It is a lot of work, and it involves just about every department here in the organization as part of that. On the next slide, I wanted to share with you just an overview of what we're calling the changing landscape in healthcare. You might have seen in the news lately that some of our partner plans are actually going through some pretty difficult times. There are layoffs happening right now at our sister plan, LA Care, that is pretty significant. We've got hospital partners like Pomona that's been in the news because of that same issue. And our forecast that we had shared with you, probably 18 months ago, was to try to get ahead of a lot of that using attrition, meaning we're not backfilling positions. And thankfully, we're actually making some good progress there. So we're not having to take those kind of measures that some of the other organizations are having, or we're not also in the position where some of our sister plans have a percentage of 35 to 40% of what's called UIS, or unsatisfactory immigration status, and that's creating a completely different issue in some of those plans. Ours is at 10%, and so that means that the membership stabilization is much, much stronger in our organization. So I just wanted to share with you that on that piece around our partners and what you're seeing in the rest of the landscape of the public plans, and even a lot of the commercial plans, actually almost all the commercial plans are going through this as well. Thankfully for IHP, we've taken a proactive approach to this, trying to get ahead of this using that attrition lever as much as we possibly can, instead of having to go down to those other measures. And so more to come on that, but I wanted to just be sure that you knew, because I know it's been in the news a lot here lately. I also wanted to share with you that the May revise, of course, will be coming out here soon. Time is just clicking by this year already. And there's an important piece to the budget for the state of California when it comes to the May revise and how it impacts managed care organizations like IHP. CMS, so the Centers for Medicare and Medicaid Services, recently released guidance to the state of California clarifying that MCO tax that is also part of the budget is actually going to end December 31st of this year. Now, it's been traditional that the governor has really relied on those dollars to backfill the state budget, and then some of those dollars had moved on to providers and hospitals like they were originally intended to through Prop 35 that was passed in November. Those two issues, though, the May revised forecast of what we're seeing is coming, which we think is going to be a little bit more difficult than what was the picture that was painted in January, as well as the MCO tax issue, we're concerned. We're concerned for the whole state. We're concerned for the health plans and for our members and providers. And particularly, there's a piece within H.R. 1 that's called the uniformity measure, which is why the MCO tax does not qualify to keep it going after the end of this year. So we'll see how the state's going to deal with that. Are they going to make changes to that? What could that look like? And we'll bring that detail to you soon. But I wanted to just give you a heads up. There's a lot of moving tiles, if you will, around the floor that we're trying to make sure we stay ahead of, to make sure that both our members and our providers and our team members are all well taken care of. So more to come on that here soon. And then finally, on this changing landscape, I wanted to be sure that you knew our provider contracting, our team is really getting down into the weeds now on changing some of our provider contracts to get much more around value-based care. And what that means is that we've had our quality pay-for-performance program for quite a while. In fact, we were one of the first in the whole country, I think, to have such a robust pay-for-performance program. But we're noticing that we really need to do more to drive that inside of the contract itself. And in fact, CMS even recently came out that with required amendments that had to be for every contract provider that was participating in our pay-for-performance program. So our team is going through an exercise over the next several months of how can we instill more value-based care within the contract itself for providers, and that's for hospitals, physicians, and other providers to make sure that the quality piece of the puzzle is always at the top. And so you'll hear more about that as time goes on, but I wanted to be sure that you knew that we're on that journey to start to look at what can we do with provider contracting to really drive more quality, more value for the Inland Empire, for our members, and to really make sure to incentivize those providers that are doing really well on the quality journey. So more to come on that soon. On the next slide, I wanted to share with you our Provider Dinner Series continues to be a hit with our physicians and providers across the Inland Empire. The most recent one was just held in Corona. We had a really great attendance at this, lots of good questions that came up around what's happening at the state and the feds, and we really appreciate this continued support of those provider dinners. I also wanted to share on the next slide a big shout out to our Chief Quality Officer, Jania Fick, and her whole team that held our very first ever Quality Pay for Performance Primary Care Provider Best Practice Summit. This was just held a few weeks ago here at IHP. It was a sold-out event, even though we didn't sell any tickets, but the registrations were completely packed out. And they held out breakout sessions with physicians and providers on best practice sharing of how we can share with one another on what's working to connect with our members. And I'm just so very proud and grateful for Jania and her team and the experts that they had to come in to speak on different topics to really drive quality, and they just did a fantastic job on that. And then finally, I wanted to share some really great news as well from Michelle Rye's team. Our marketing communications team actually won Best in the West award. This is an award that was provided by the Public Relations Society of America, specific for an advertising campaign around mental health. And the mental health campaign starred Abby Carter, who was the American Idol winner a couple of years ago. And this actually was the best of the best across 5 states in the West. And so I'm just so proud that our team got to have this kind of recognition for their work, to not only have an excellent marketing campaign, but more importantly, be able to share very important and very meaningful and needed resources that are available to folks that need behavioral health and mental health support. So big kudos to the team there in the Marcom group as well. Chair, that concludes my report for the day.
Thank you. Lots of updates. Questions, comments? It looks like your team has, with that crystal ball, has a lot of work to be doing the next year, and as things sort out the way they do. Anybody else have any comments?
I would just like to say it continues, I think, to say to us the amount of dedication and the commitment to excellence, and again, to all those things that set IHP apart as being really community-centric. So thank you to both of you.
Thank you. Okay, we'll move on to our Governing Board Compliance 23 fast slides. All right?
I can't promise. Good morning, Chairman Hagman and members of the board. Today, I have the pleasure of conducting this year's Compliance, Fraud, Waste, and Abuse and HIPAA Privacy Program training. And I know that you've all been looking forward to this. Next slide, please. By the end of this presentation, the board should have a stronger understanding of IHP's compliance program structure and its operations, your role as the governing board in the oversight of this program, and how you might effectively exercise these responsibilities. Next slide, please. So just real quickly, I would like to give the board an overview of our department structure and compliance, starting with the unit on the far left. Internal Controls very recently joined compliance. This team performs internal audits with an emphasis on protecting the plant's assets by ensuring stronger controls and identifying opportunities for efficiency. The next block here is represented by our 2 regulatory affairs units for Medi-Cal and Covered California, as well as Medicare. They take the lead in regulatory audits, similar to one that Jared just shared with you during his update. They ensure timely and accurate submission of regulatory reports, and also serve as a consultant to our business areas should they need regulatory research and interpretation. The third block here is our policy and regulatory operations, which is kind of unique to IEHP. This team supports business areas in their quality and regulatory review of policies and procedures, and also leads cross-functional implementation of regulatory requirements. The next one is audit and oversight, as well as systems and operations. Combined, these teams are responsible for routine oversight of the plan, review of internal departments, as well as our vendor delegates, and also responsible for the implementation of the compliance training and department operations. Our privacy and ethics team is responsible for the HIPAA privacy program. They investigate potential PHI exposure and breaches and complete associated regulatory reports as well. They also review, implement, and in collaboration with human resources, enforce the plan's code of business conduct and ethics. And in the last unit there, certainly not the least, is our Special Investigations Unit, responsible for the implementation of our Fraud, Waste, and Abuse program. They investigate potential FWA and completes associated regulatory and reporting requirements. Next slide, please. As members of the governing board, with your understanding of the health plan, its mission, and its strategy, you are in a very unique position to actively assess the adequacy and effectiveness of our compliance program relative to the size, the complexity, and the strategic vision of the organization. Also to ensure that the plan and the board are making strategic decisions that strengthen the compliance program. Next slide, please. In addition, the board also sets the tone for the rest of us at IEHP by challenging us to ensure that we have adequate and transparent review of compliance activities and their outcomes, and effectively identify and correct issues of noncompliance. Also, that we maintain an effective compliance program and foster ethical culture at all levels of leadership and throughout the organization. Next slide, please. So what do we mean when we say effective compliance program? It is one that prevents, detects, and corrects issues of noncompliance. It's one that is fully implemented and tailored to the organization's unique operations and circumstances. One that has adequate resources, one that promotes our standard of conduct and establishes clear lines of communication for reporting noncompliance. If you have had other compliance program trainings, this is often referred to as the 7 core compliance program elements, which are on the next slide. Thanks to the hard work of many in the department, our executive leadership, and the compliance officers that came before me, IHP has all 7 elements of an effective compliance program established, and we are, of course, continuing to work towards further enhancing these at IEHP. Next slide, please. Here you will see just some examples of how the governing board can effectively exercise their oversight responsibilities, and I'll just go in a little bit more detail in the coming slides. Next slide, please. So we support the governing board in the review of the compliance program activities by sharing findings and outcomes at the quarterly governing board compliance committee meetings. So Jared had shared earlier that we will be sharing with you the preliminary and final report from the DHCS audit. That information, of course, is shared to the larger board as well as GBCC, just as an example. Next slide, please. We seek your review and feedback on these reports that we share with you. We encourage you to ask questions to ensure transparency in the information you are being provided, and challenge us in making sure all levels of leadership from all business areas are actively executing the compliance program, mitigating plan risks, and implementing corrective action plans. Next slide, please. We also seek your leadership and support in making sure that compliance is not just an afterthought, instead that it's baked into our operations and decision-making at IEHP. Challenge the leadership here to model a culture of compliance by asking us how our decisions align with regulatory and compliance program requirements, how we've identified and mitigated risks associated with these decisions, and how these promote our code of business conduct and ethics. Next slide, please. The Office of the Inspector General encourages governing boards to obtain from as many sources as possible the information you need to ensure a comprehensive view of organizational risks. Again, we at IEHP are committed and do support you in fulfilling this responsibility through our monthly meetings and our quarterly reports. Next slide, please. We also support the governing board in identifying and monitoring risk areas by sharing outcomes from audit, monitoring, and other oversight activities, as well as regulatory publications, external audits, and enforcement matters. Next slide, please. GBCC is one that I think a couple of you are very familiar with. To strengthen the board's oversight of the compliance program and in accordance with our contractual agreement with DHCS, IHP, with support from our executive leadership, established the GBCC, comprised of the board chair, vice chair, and a third member of the governing board. So we welcome Supervisor Spigo to GBCC. We also have our chief officers, myself, and our director of compliance and risk management serving on this committee. We meet on a quarterly basis, and in addition to the governing board at large, GBCC has closer oversight of the compliance program to ensure that we are effectively implementing the program, we have adequate resources, adequate risk mitigation, and that the Executive Compliance Committee is operational and fulfilling its role. Now, on the next slide, I'll be shifting gears to our fraud, waste, and abuse program. The FWA program falls under the auspices of the SIU in compliance, and through this program, we maintain various mechanisms for members, providers, external partners, team members to report and identify suspected FWA. We also work with business areas to ensure that we have the appropriate controls in place to detect and prevent FWA, as well as investigate suspected FWA and report these to our regulatory agencies and law enforcement as appropriate. Next slide, please. Well, this is always the tricky slide for me. There are three main terms in the world of FWA that I just want to quickly review with you. Fraud, the keywords here, of course, are knowingly and willfully committing or attempting to commit a scheme to defraud a healthcare benefit program. In short, there's intent to deceive not just IEHP, but our CMS, DHCS, and our other regulators for their personal or financial gain. Second is waste. So this is the overuse of services that directly or indirectly result in unnecessary healthcare costs by misuse of resources. These are typically a result of inefficiency and our lack of controls. Abuse, this is the improper use of services that result in unnecessary healthcare costs, improper payment, services that fail to meet professionally recognized standards of care or medical necessity, and these may not involve intentional deception necessarily. On the next slide, we just have a few examples of fraud, waste, and abuse. So just to name a couple here, knowingly billing for services not furnished or supplies not provided would be considered fraud. Conducting excessive office visits or writing excessive prescriptions would be considered as waste. And unknowingly billing for unnecessary medical services would constitute abuse. Next slide, please. The privacy program falls under the auspices of the Privacy and Ethics team in compliance, and through this program, we also maintain various mechanisms to report potential breach or the inappropriate disclosure of PHI. We work with business areas, including IT security, to ensure that we have appropriate safeguards and prevent inappropriate disclosure of members' PHI. We also investigate potential inappropriate disclosure of members' information and complete any associated regulatory reports. On the next slide, just real quickly, some key terms in the world of HIPAA privacy. Personal identifiable information, these are information that can either identify the member or there is a reasonable basis to believe that the information can be used to identify the member. So examples are the member's IEHP ID number, their social security number, their email address, their photographic images, while protected health information are PHI plus health information that relates to their past, present, or future physical or mental health condition. Privacy breach would be the unauthorized acquisition, access, use, or disclosure of PHI which compromises the member's security or privacy. Next slide, please. I'm not going to go over this slide, but here you have examples of the types of PHI breaches or unauthorized disclosure that we see today. I would encourage you to take a look and make sure that you are also protecting your own information. Next slide, please. So as a reminder to all of us, we all have a stake in the compliance program. We all have a responsibility to prevent, detect, correct, and any form of non-compliance, be it non-compliance with regulations, privacy laws, or code of conduct and ethics. Such non-compliance can in turn harm our members and result in penalties to the plan, providers, and other partners. And you as our governing board are in a very unique position to help us maintain an effective compliance program. On the next slide, to help us all fulfill these responsibilities, we've made and maintained various ways to report compliance issues, which I'm not going to go over, but you do have access to them on the executive summary. Next slide. Before I open the floor to any questions or comments that you may have, just a quick reminder to please review and sign your attestation forms to confirm that you've completed this year's compliance training. Are there any questions for me?
I think you did that pretty well.
She did.
Yeah,
Record
Karen.
time.
I think Eileen's hand was first.
That's okay.
Okay.
Karen's first.
Wow.
Wow.
And I've heard this before, and before that, and before that, so I do attest that I hear it every year. But every time you share, my mind goes, particularly after the public comment that we had today, because her comments kind of fit in, but I'm trying to figure out how they fit in. Because we were here in an open session, I'm sure that it's going to be handled. But let's say that she had come to me.
Mm-hmm.
Would that be a compliance because of the harm to members? How do you determine where and what to do with this?
I think the comments that we heard today would need a multi-pronged approach. So compliance will definitely need to be involved in terms of working with the vendor on oversight of the services that they are providing, but also the business area that owns the contract, our quality of care investigation process, I think, would also be involved. But I can rest assured that for vendors that we bring on board, we do have a comprehensive vetting process that we take through or that we go through before we contract with a provider. So that comment was really very difficult to hear, and we are committed in making sure that we address the concerns for the member.
So if one of us would receive a comment, which we've all, and I usually just say, hey, Jared, and pass it to him. If I was to do it the process way, where would I go? Still to Jared? Because you gave us all these numbers and
Yes,
stuff, and it's
yes,
like,
yes.
you know, since this is our governing
Yes.
board session, where do we actually go?
That's a really good question. I mean, I think I would say still Jared as our CEO, and he's really good about looping in the right leaders at the organization. However, if the board were to send it through the compliance hotline, we will do the same and make sure
Okay.
that our executive leadership is informed and the right business areas are informed as well.
Yeah, I just like to share with Jared, just so he knows that members would be contacting us, and that he definitely can speed up the process by going to the right place.
Yes.
Here, I'm sitting here hearing, and where would I go? So, thank you very much. This is very, very informative.
Thank you.
Thank you.
Yes.
Eileen?
Just wanted to say, Lourdes, you've been with us for a long time, and you have grown this program into what it is today, what we're all experiencing. Each year, you bring a new perspective that I've found very interesting in this, and you make what could become just the same old, something that is extremely important in ensuring the fact that we understand that this is collectively our responsibility. So I thank you for that. The only other question that I had for you, Lourdes, was I know this has been quite an interesting year, 2025, and I was wondering if you could give us a sense of what the experience has been like for you and your staff with all that you've been through this last year.
That's a loaded question.
I know.
I'll try. I'll try my very best. 2025, I think the biggest focus for the compliance department has been fraud, waste, and abuse, and I think we see that also at the state and federal level. So with support from our executive leader, we've really been challenged to make sure that we have the right processes and the right systems in place to detect FOIA and, in collaboration with our legal team, be able to make sure that providers who may not be acting in the best way are pursued and dealt with as appropriate. Also, our department has grown quite a bit in this. The focus on SIU, I think, allowed us to also see where the opportunities are on the privacy side. So 2025 has been a lot of learning and growth for compliance as a whole. Also, I think that on the regulatory side, the state really has not let up on new regulations, new non-traditional benefits. So I think the resources that we have, the challenge is to be able to do more to support our business areas. And I think we've been doing well in that area, but also seeking to improve for 2026. I hope that answers your question.
Well done. Thank you.
Thank you. Any other questions for me?
No, we just got to make sure we sign our little form,
Yes, please.
and the clerk will pick it up after. Thank you for that.
Thank you so much.
We'll move on to financial. Jared's going to
We actually have a board education.
Yes, we have one more item,
Oh,
sir.
do we?
Yeah,
Yes.
it is our board education item.
Oh, that's right.
Yes, for Cover California.
It's the compliance day.
Good morning, esteemed board members. My name is Wayne Guzman, and I'm joined by my colleague, Dr. Jezebel Urbina, and we have the honor this morning to share with you about the open enrollment, which is very important this year, especially given all the changes that we've seen in this year to eligibility, pricing, benefit updates. Next slide, please. Open enrollment runs each year from November 1st to January 31st. And it's a time when our members have the opportunity to review, update, make decisions regarding their health care and those plans that fit best for them and their family. It's also a time where we at IHP can truly demonstrate and live our values, our MVV, by assisting them in that education, working through that process. And so we have an internal enrollment team, certified agent partners, as well as navigator, who assist those agents through that process and obtaining the information and making the decisions that are best for them, ultimately fulfilling our mission of providing optimal care and vibrant health. Additionally, next slide, please. You will find on this slide that we really operate in a very competitive environment filled with commercial carriers who have been part of the exchange since 2014. And what this slide is designed to demonstrate is really the sensitivity of market share changes with respect to pricing changes. My colleague, Dr. Urbina, will go over that right now, as well as other updates and strategies we implemented. But I simply wanted to remind you all that we exist to help strengthen the organization by driving membership growth, but doing it in the right way, with a heart, with empathy, and living our values as we help our members. Jezebel.
Thank you, Wayne. Good morning, everyone. Jezebel Urbina, Director of Enrollment. Next slide, please. I want to talk a little bit about our price positioning for this open enrollment. We were at third lowest silver tier. Now, there was some changes due to the gender affirming care piece, but that didn't happen until January 31st. Excuse me. So we essentially ran all of open enrollment as the third lowest price. Next slide. Okay, and that was our second lowest rate right there. Next slide, please. So I want to go over some of our goals for the 2025-2026 open enrollment. We had goals for membership, both new and renewal. We also had some retention goals to help members keep their IEHP. And then this year, we added some risk adjustment support goals that I'll talk a little bit about. And of course, outreach and education, educating our members of all of the policy changes and results of that and what they can expect. Next slide. So some of our strategies, our goal was that we wanted to retain at least 30,000 effectuated members. When I say effectuated, I mean they have paid, they are in good standing, and their membership is active. That accounts for about 60% of our previous, entire membership. Now, we did that by outreaching to our terming Medi-Cal members through a direct partnership with the counties, and also through our relationship with over 700, contracted brokers that we contract with. We also enforced, and really reiterated our value proposition in that, we are the health plan with the heart, and we do focus on our, underserved and low-income population. So we really wanted to make sure we kept that message there. And then, of course, binder payment collection. We wanted to make sure that we did everything we could to help our members pay for their plan, whether that means, being available in person to take their payments, take their payment over the phone, or just help them, be able to make that payment on their own. We also did some risk adjustment support. So this is something that was new for this year, but something extremely critical. Helping at least 70% of our new enrollments that were assisted by our internal team answer some questions that would really help us identify some of our high-risk members. As you know, we have a huge decline in overall statewide membership. So what that says is the ones who are staying on, it's because they need the care, they need the insurance. So that there is definite potential that these are high-risk members that we really want to make sure that we are identifying at the time of enrollment. And then we also did some quality trainings to our agent partners, having them be aware of what's going on and how we operate as a plan to help with our quality. Okay, and then for outreach and education, we did live webinars, both English and Spanish. We had social media campaigns and agent partner trainings that really helped with that as well. Next slide. So some of the challenges that we had, of course, price changes as a result of some of those legislative measures. We are no longer the lowest price silver. So what that means is that we are not receiving any more auto enrollments from our Medi-Cal membership. Also the enhanced premium subsidies expiration, the price increase, over 104%, average price increase. Also DACA are no longer eligible for subsidies. And then something new that, our enhanced silver members weren't used to is having deductibles. They didn't have that before, so now that they will have that, that's also going to be a challenge. And payment challenges in general. A lot of people are canceling their auto pay because they just don't know if they're going to be able to make their monthly payments. And then effectuation, again, that's a direct, related to those payment challenges is that, we have people that renew their coverage, but they are in grace period because they simply don't know if they're going to be able to pay. Okay.
Question before you move on, if you don't mind.
Yes.
When I was looking at our competitors, the other people in this market, a lot of those are for-profit and we're a nonprofit. I'm just wondering how they beat us and, how do we go from number 1 to number 3, I guess?
Well, what I can tell you, and from experience, because I worked for Covered California when it was first implemented, 2013, 2014. Market share fluctuation the number 1 driver for that has always been price point. And
I understand that. That's
yeah.
what I'm trying to figure out since we're large and nonprofit and run pretty lean. versus a for-profit,
Mm-hmm.
how do we not beat them?
Risk adjustment is something that we can definitely work on. LA Care is sister plan. They're currently the low price leader. It can be done. And the result of not being is we're essentially 3,000 to 4,000 members that we used to receive from auto assignment every month. We no longer have that. And so if we can really work on that risk adjustment,
Yeah, we have to wait another year now for the next open enrollment for that to happen.
yes.
And I get across the board, there's going to be
Yeah.
fluctuations of the members coming with the
Right.
new rules and the difference in prices, but
Right.
yeah, I like to keep striving that we should be the best value in town.
And we know we have what we need to work on, and we're developing those strategies now to be able to, really focus on that for the coming year.
And it wasn't that much of a price difference in number 2 and number 3.
It wasn't. It was not a huge difference, but, even, we know 5,000 of our members left to another lower price plan. So it makes somewhat of a difference, yes.
I guess some goals there. Yeah, Karen.
So I realize, and this is my one thing, open enrollment. If I get that, because we all have that in our organizations, and I realize that we have to have it, but if there's somebody new, who's got a change in their life, they have to wait for open enrollment, or we could bring them in if they.
If they meet the criteria for a special election during special enrollment, they can. So, they got married, they just moved, maybe they had a baby. Any situation that would open up that eligibility to be able to enroll, yes, they can do that any time of the year.
Now, if they left and there was a change, could they come back, or do they have to wait the full year?
If they don't have a special election, they would have to wait. So if they, for example, they dropped, they didn't pay, if they don't have a valid special election for whatever reason, they won't be able to enroll again until the next open enrollment, unfortunately.
So if they lost their job, say?
That's a special election.
Okay, I'm trying to.
Yes, that's a special election. So loss of coverage because of loss of employment, that would be a special election.
And Jesse, what was your question since you raised your hand? He whispered to me to ask. You can ask.
I still don't understand, kind of piggybacking with Kurt. I'm still trying to comprehend how we changed to third when we are supposed to be a nonprofit. Like, is it because we're so big? Like, what's the reason? Because you said we're working on it, but you didn't say what we're working on.
Supervisor, I'll jump in here and share a little bit more detail. If you go back a couple of slides, there were 2 years that we showed you. I don't know if the team can go back a couple of the slides to show. Keep going. There you go. If you see here the rate change between 24 and 25. You'll see our rate changes there on that column that has that box around it. It says, it starts with Kaiser Permanente, it says 5.7, and we're at 2% there. And if you jump over here to the 25-26, we're at 18 essentially. For us, what happened, you might remember, we're brand new into this, and we didn't really know what we didn't know when we initially priced the product at the very beginning. When we priced it at the very beginning of our cycle of joining Covered California, we actually priced it way too low. In fact, we were way too low. That's why you probably saw the losses that we had in this line of business, and also because our administrative costs, we needed to do some work on that as well, of vendors and whatnot. Well, we tried to make up for that in 1 year instead of spreading that out to try to make sure that we're at least breaking even as close as we possibly can. And that's why in this 2026 budget that Tim and the team is going to actually share with you here in just a little bit, you're going to see that this is our first time where we're basically breaking even on Covered California. Maybe a little gain. Is that right, Tim? Just a little bit of a gain. In the projection. Yeah, this is our forecast. So we kind of shot ourselves in the foot, because what happened is when we initially started with Covered California, we priced it too low. We tried to make up for that low pricing piece in a 1-year period instead of a 2-year period because we kept it low in that second year. And so we're learning and we're evolving, and that's why today, as they shared with you, we're actually the second lowest. So because of some of the changes that just took place within the state, and if you go forward to a couple of slides, you'll see now we're actually the second lowest. We'll see if we can take you forward here. One more. So right now, this is our price point of where we sit as far as our cost for this silver plan rate that you can see compared to everybody else on this slide. So Health Net's at $354, we're at $361. So today we're at the second lowest. And to your point, Supervisor Armendariz and Supervisor Hagman, we need to be the lowest. We believe we need to be the lowest because we're a public entity. We just had a shift in cost because of that problem. We were trying to make it up in 1 year instead of spreading it out over 2 years. Does that help a little bit with more detail on that? I hope that helps make sense.
Still taking it.
Yeah, no problem, no problem. Go ahead, Jess.
Can we forward to the lessons learned slide? Next slide. So as you could see here, we did have the highest renewal. However, I do want to point out that this was our members that intended to renew with us. That doesn't mean that they paid. So the intent is there. Unfortunately, we still don't know. We have over 14,000 members right now in grace period who we don't know are going to be able to pay for, to be active for January. Next slide. So lessons learned, we definitely learned price matters. Almost 10,000 members dropped coverage altogether or switched to different plans. Very confident that becoming low price leader again is going to help recuperate some of that membership loss. And we learned about member loyalty. We know that 91% of our members wanted to stay on, but we also know that some, unfortunately, and many are not going to be able to. Only 58% to date have paid their premiums, so that's what we do know. And then we learned what our member profile is. 96% of our members are below 400% federal poverty limit. So 78% of those are under the 250%. So that is who we serve, and those are our members. And to add to your question, that also is another challenge for our risk adjustment, because we do know that Medi-Cal members historically, are higher risk. And so it becomes, for our local plans, who serve that population, to tackle that. Okay. Next slide. Concludes my presentation. Any other questions?
Anybody else got anything else? No, it's like the guessing game of what's the right level where you at least break even, but you got to be the lowest too. So
Yeah, exactly.
just tell the other plans and tell us what you're going to charge this year.
until the last day when they,
Yeah.
no intel information. So,
Thank you.
Thank you.
Thank you for everything. And that finishes our board compliance, right? Madam Clerk, we got two done?
It does.
Moving on to finance.
Now we're doing a financial. Jared and
Yeah, Tim, I'll turn it over to Tim to take it away.
Thank you, Jared, and thank you to the board for listening to me drone on. I will try to be very quick, keep up a pace, but if you have questions, please feel free to interrupt at any point and ask them. What you have before you is the December financial statements, which also include, of course, the year-to-date. So that means that this is the entire calendar year 2025 financial statements. And if you'll look for the December to year-to-date numbers there, which is on the right-hand side of the page, you can see we're going to finish the year losing $5,600,000. While we were hoping to break even, that really essentially is break even in an $8.5 billion plan, because that's 0.00, I don't know, 3 or 4. I mean, it's very small. And again, as we've discussed in the past, that's a tremendous improvement from 2024, which saw significant losses. And we'll touch on this in the budget, we're really looking forward to 2026 as being a year of improvement and seeing a somewhat similar improvement from 2025. And we will get to that later on. December had a loss, which is the first column there. I guess the other main thing I want to bring up is if you look in the actual column for non-operating income, 118 million, that is investment income, as well as some other technical adjustments made. And that's basically covering the loss that you see in the variance between the budget and the actuals for year-to-date for the year. So our investment income is making up for that we spent more in healthcare than we had projected. The revenue came in actually a little bit better than was budgeted. The administrative costs came in better than was projected, but our healthcare costs still remain higher than we would like. And that really has to do primarily with claims from providers, how much we've paid. There's a greater number of claims and somewhat higher prices. And I would say that's also related to Covered California is a similar thing, to get back to the earlier question. Good thing I have her. So hopefully you could hear all that. But we are encouraged, we are in the right path, and we've made corrections from prior year. Next slide. All right, just a graphic representation. The orange line is 2024, and the blue line is 2025. You can see the gap between them is the difference between losing 375 million and basically breaking even by losing 5 million. Next slide. So we have 3 products, Medi-Cal, a D-SNP Medicare product, as well as Covered California. The Medi-Cal product, though, makes up the bulk of our overall business, so I'm going to just touch on it. And basically, almost everything I said for the consolidated statements that overall would apply to the Medi-Cal statement. So we don't need to stay too long on this. I know you have a long agenda today, so I'm going to move forward and just touch briefly on the D-SNP and Covered California unless you have a question at this time.
Nope.
Okay, next slide. One more. Okay, D-SNP. So this is a special needs plan for dual eligibles that also have Medi-Cal coverage. This is a Medicare program. You can see we're closing at $20,700,000 loss. Again, the loss really shows up from the projection where we were hoping to make a small profit in the healthcare expense slide, the total medical cost. We actually achieved a little bit more revenue than we had anticipated, as well as our operating experiences, which is our administrative costs, were also positive. That is lower than we had budgeted. So that's positive. We think, though, this is on a good trend, and we will be able to make it more profitable in the future. Okay, 2 slides. Forward. Covered California. Okay, here you can see we lost a significant amount of money relative to the size of the product. We lost $57 million on Covered California. Unlike the prior 2 products, you can see revenue, medical expense, and administrative expense all were more than we budgeted. So we really have work to do on all 3 levels. If I can call your attention, though, to the last 2 rows of the chart, the medical cost ratio, meaning as a percentage of revenue, how much is our medical cost? And then right below that is the administrative cost ratio, meaning of our revenue, what percent is spent on administration. And if you look to actual December to year-to-date for this product, the medical cost ratio is 99.7, so we're spending on healthcare almost as much as we're paid. Obviously, it's very hard to achieve any profitability when you're spending as much as you're getting paid just on the healthcare costs. Our admin costs, though, here are too high also. You can see there 23%. We really don't want to stay there, and we think we can improve on it. And we think we can improve in all these areas in the coming budget, which you'll see in the next presentation.
So it's mostly on stuff that we can control then on this product? You think it's internal more than external? Because we just, from the last report, obviously we're raising our premiums up a little bit.
Well, control may be a little bit too strong a word. We certainly have a lot more control over the administrative costs than the healthcare side. But as a new product, some of that just takes a while to ramp up and size it correctly to the product. That's going to be a little bit of a struggle this year because we're not sure how much decline in enrollment we're going to have, and that's still kind of shaking itself out. But we have more confidence we'll do better. Some of the administrative costs, which we're going to improve on, we already started to take action on, is we had a vendor who did most of the claims processing and other services, and much of that we're moving in-house. We think we can do more efficiently than the vendor. I mean, it's not unusual when you use a vendor for them to be more costly than yourself.
Yeah.
You're usually doing it when they have more expertise than you. But I would say on the competition, I just want to add something to what's been discussed so far. I think part of the issue in terms of the medical costs is we probably pay, in general, and I'm sure people could give me examples of where this isn't true, but pay better than most of the commercial plans to our provider community. Not always, but a lot of the time. And so that makes it harder for us to be a less costly product because we're trying to develop a product that helps the community and provides the care we need. But in addition to that, sometimes commercial plans actually buy market share by purposely lowering their bid price.
And next year they
Yeah, and so the next year it comes, and so there's issues there, particularly if they've had a change in management or investment by any funds that want to see an increase in revenue. So there's often multiple things going on, but it's been true for Cover, as mentioned here, it's been true for Cover California throughout, that price, even very small price differences to the member drive membership one way or another. I mean, price differences of $10 per member per month. People will leave for that amount of money, which is an interesting comment. So we have work to do here, but we think we're headed in the right direction.
Thank you.
Next slide. Next slide. So this is the balance sheet for December compared to November. Nothing too exciting. The only thing I want to call out is the net position line, which is also our net equity. You can see the decline, about 24 million, and that's due to the losses. Next slide. This is our T&E cash on hand. So our T&E, which directly correlates to our profitability, shows a decline due to the loss from November to December. You see that it's 367%, while our cash on hand remains unchanged. So it's interesting how cash on hand and net surplus or income is not always linear, right? There's changes because of how cash on hand is more in terms of liquidity. So another way to look at it, I always tell people, is net income is really a measure of profitability over time, while cash on hand is a measure of liquidity at a specific time. So, okay.
Thank you.
All right, next slide. You can see this is a product that remains a little bit of a challenge. The blue line, which is our 25 line, is quite a bit above the budget line. Next slide. Transportation. This is an area, though, we made substantial gains during the year. But again, we are revamping that program, trying to improve both the services delivered as well as maintaining an appropriate cost profile. And we think with our changes, it'll be a better program. All right, switching to 18. Skipping forward 5 slides. Okay, long-term care. And I might just note that inpatient and long-term care make up a substantial part of our overall healthcare costs. And to the extent you're worrying about healthcare costs, those are always going to be areas you have to attend to. So if you look at the results there for the last 3 years, as well as the trends showing what was the increase from year to year, you can understand very quickly why calendar year 2024 was a significant loss overall. The inpatient costs, and long-term care costs, but especially the long-term care costs, increased tremendously in 24 from 23. You can see there it's over a 40% increase, which is incredibly high. You can see there's been an improvement in terms of the rate of increase, but that percent increase is actually higher than we would normally get in terms of revenue increases from the state. So we'd like to see that rate of growth decline. The state doesn't normally give you 10% or more, though we did secure what is hopefully a good rate for the coming year. But
Again, as you dig into the numbers, what is what attributes that cost of, is it providers, is it?
Well, the healthcare
use?
costs really, of course, are a factor of the utilization level, how many days are provided, as well as the cost per unit, or what do we pay the hospitals, and what do we pay the skilled nursing facilities. We're paying not outrageously high rates, but a little bit higher than we probably should be, given our structure. We've undergone a process of examining quite carefully over this last year what we're paying, what our competitors are paying, and what does traditionally Medi-Cal pay to make sure we're coming in. So some of it is what we're paying, that we're paying more than others are paying for certain services. And that's probably a large part of it as well.
And Jared, what's the plans from the operational level on some of this? Because we got a lot of data, and I get covered California is still fairly new products. We've got to dig into data a little more. But, how do we find that sweet spot where we don't lose money, but we're being competitive and all the rest of it?
Yeah, I think once we get through this, hopefully soon, we can get to the budget for this year, because you're going to see that. You'll see that some of the changes that we've made for 2026 and some of the forecasts that we have, we're actually feeling in a pretty good spot on all 3 lines of business. And again, this is forecast based on what we know today, but there's been a tremendous amount of work that the teams have done on the administrative costs, as well as what Tim is sharing with you, just retooling a little bit of looking at the data of our comparative position of what we're paying our providers. So I think hopefully we can move to that pretty quick.
I have a quick question. Am I the only one, or did I just not hear? Why is May so high in the budget? It's kind of like jumping out at us and no one's addressing that. What was that about?
Well, I wasn't here in May, but...
Oh, don't pass the buck.
Oh, darn. I did ask that question myself, and it had to do with both seasonality and some other technical adjustments of moving through the year. And I think it really had more to do with the budget than it did with, as you can see, the healthcare cost isn't rising as much for that period. So I don't have a good answer for you. I can come back with one if you'd like, but.
I just can't believe nobody else asked that. To me, it just stands out like a sore thumb.
It does. I'd like to take a eraser to that.
You can't erase it till you tell us why it's there.
Okay. Well, hopefully in the next year we won't see any. But yes.
The other thing,
Good
since I
question.
got you, when you talked about on that slide that, I don't know what page it was, T&E and cash on hand.
Mm-hmm.
I am this person on acronyms. Ask Jared. Why do we have an acronym for T&E and cash on hand is spelled out the whole time?
Well, that's probably because everybody in the state, instead of saying tangible net equity, which is a mouthful, just call it T&E. And even the regulators refer to it as T&E. So we're just mimicking what everybody used. But in our internal documentation, we refer to cash on hand as COH.
Well, that's what I was, thought it was kind of weird, so that's all.
Yeah.
I see I do listen.
You do. Well, sometimes there's so many abbreviations, though, that it's hard to read through people talking about healthcare and being able to follow, because just there's hardly any words. It's all abbreviations, and
Okay.
it is a
Understand what we go through. We're on different boards, and everybody has, and suddenly you got the same acronym on 3 different boards, and it's like, okay. So that's kind of why I'm so focused on acronyms, because I got to make sure I'm sitting in the right place with the right words.
Yeah, sometimes I see them, and that acronym means something else somewhere else,
Yep.
and I'm there.
Yep.
I don't follow. So.
All right, thank you.
I understand your question. I just want to comment quickly on Supervisor Hagman's question of, in terms of the costs and getting the right spot in paying the providers enough to have a quality network, but the right amount so we can be cost effective. It's the most difficult part of being a public plan, is achieving that balance. If you're in a commercial plan, it's more of a strict business decision. What do I need to satisfy things and keep market share and be profitable? And I'm sure commercial plans look to have quality too. But for us, it's not just that. We want to make sure we're paying enough to get all the right services, but also really you see yourself as a community plan. So that means you have to try to pay the providers really as well as you can. And that's just kind of a fine line that sometimes is harder to achieve. But
I get that. And obviously, if you want to be a profitable company in anything, you have to understand your cost and be as accurate as possible. That's why when it comes back to the premiums, it's got to be focused on that balance of whatever. And I'm sure that we'll get down to it. And then the second part is for the previous discussion is how to keep fraud, waste, and abuse out of the system too. And we focus more on that back end and not waiting 6 months to react to something. That's the real-time monitoring that needs to happen on our level to make sure that once we do get that right number in the perfect world, then we're making sure there's not the leakage from another direction.
all very good points. Okay, next slide. Community supports, speaking of a challenge. But if you look on this chart, you can see significant progress has been made, and that we've certainly got the expenses to more closely track the budgeted amounts for the year. So that was really through the kinds of things you just mentioned there. Digging deeper into the data, restructuring agreements and the network to try to maintain the service, but also to maintain an appropriate cost level. And I think that's the end. I have more, but we don't necessarily need to go through them. They pretty much were tracking how they were in earlier reports, and we try to hit the larger ones there. But if you have any additional questions, I'd be happy to answer.
No more questions on the board. Thank you. I think it's we're hitting a record on PowerPoint slides today, though, with all the compliance and stuff. And we got more. Because now we're going to go to adopt and approve the fiscal final year calendar for 2026, right?
Yep. Yes. Okay, so I don't know if you have additional slides after this, but we'll try to go through quickly. But again, please raise any questions you might have. So this is the 2026 budget. As you'll recall, earlier or late in 2025, we passed a preliminary budget. The primary reason it was preliminary was that we did not have final rates from the California Department of Healthcare Services for our Medi-Cal product. So we needed to do that before we could come back with a final budget. Many items in here, not just the revenue, but on the healthcare and administrative side, remain the same from the preliminary budget. We'll really try to highlight more changes that happened and other big highlights. So on page 2 here, you can see both the consolidated line for our business, shaded in green there, as well as the individual products. We're projecting a $207 million surplus for 2026. We feel reasonably confident that we'll be able to achieve that. And that will help us improve the cash on hand as well as our T&E levels, because we do need to keep improving on those levels because we are below really the average of, for instance, all of our public plans. So we definitely want to improve in each of those measures. As you can see, Medi-Cal still makes the bulk of that surplus, but it's also, we see an improvement for the DSNP and Covered California, as we mentioned here. And if you look at the individual medical loss ratios and administrative ratios, you can see that we are closer to achieving all of our ideal targets, keeping the admin low, keeping the medical cost really as much as possible below 95% and often more. Most of the criteria put out, particularly in the media and some of the things we deal with, refers to 85%. That, that's like a standard, and you have to pay back money if you're, we're not even close to that. We're paying way more than that. And really, in some ways, that's purposeful. Again, going back to that balance we were talking about earlier. But once you get to 95%, well, then it's very difficult to break even because it is going to cost close to 5%. And so that doesn't leave for admin, so it doesn't leave any margin there. You can see the projections for all the products show a surplus. The DSNP and Covered California, it's the slimmest of margins, but we do see an improvement in all those areas. I will add, though, that the administrative budget for overall is even less than last year. And you can see last year, as we've discussed, we made significant improvements throughout the year, both in terms of FTEs, our vendor contracts in these other areas. That 6% is probably the most ambitious of the percentages, or all the administrative percentages are probably the most ambitious of them. But we wanted to put a target out there for those areas that we have more control over. So we're confident for that. Any questions on this page? Okay, next slide. All right, basically you see the last 3 years and you see it on a per member per month basis. You can see that revenue increased substantially. In 26, we are projecting from 25, and the cost will also increase, but you can see the gap between the medical cost orange line and the blue line, and that really represents the $200 million we were just discussing. On the box right next to that, that's really showing the administrative costs. And you can see there on the blue line where we were trying to, rather on the red line or orange line, you can see what we were trying to achieve in terms of operating expenses. And we really have flatlined our operating or administrative expenses there. So that's definitely something we wanted to do. And I will add that gets increasingly difficult when you're having declining enrollment to keep your administrative costs flat, because you really just have fewer people to cover all the areas, and some of the areas are fixed costs, so they're not really sensitive to membership. Next slide. Okay, this is just the highlights of the budget. So the most significant part of being able to project a surplus this year and enable us the opportunity to replenish our reserves to something closer to what they need to be and are required to be in some cases, was the increase in the premium rate for Medi-Cal. But we continue to have a number of areas, initiatives where we're working on as discussed here, fraud, waste, and abuse, the community supports arena, the transportation initiatives, and as I believe Jared indicated earlier, or other speakers did, we're really going through a comprehensive reevaluation and contracting with our providers to make sure we're getting the best contracts out there. And so we are continuing to work in that area, and I'm sure we'll achieve further efficiencies as we go forward. The administrative cost avoidance strategies are really, again, continuing what we started in '25, limiting the number of new hires, and we're really trying to also retrain or reallocate existing staff to cover existing roles, and then reducing full-time equivalent positions just through natural attrition. All right, next slide. This is Carol.
Hi. Hi, my name is Carol Chiu. I'm the VP of Actuarial Services. I'm going to kind of quickly go through the next few slides of our final CY 2026 projections. Membership projections is pretty consistent with the last version that we presented back in December. We're estimating at the end of 2026, we're going to be at about 1.4 million membership. All lines of business are expecting to decline, as you kind of see in the earlier, Jared kind of share what we're seeing in January and February numbers. All lines of business kind of getting impacted by HR1, the expiration of the enhanced premium tax credit from, the CMSI, DSNP. There is a lot of regulation changes on limiting all of the benefit flexibility. So all kind of impact the membership enrollment for our line of business. Next slide. The next few slides kind of go through each line of business experience projections. They are pretty similar except Medi-Cal, where we get the final revenue from the state. So it got updated with the revenue projections. Cost projections also get updated along with some of the assumptions in the final prospective rate from DHCS. There are a couple of the risk-sharing mechanisms remain for ECM as well as the UIS for state-funded services. They did take away the risk-sharing mechanism on the major organ transplant, so we have updated the projections on the expense side to reflect the expectation on expense are aligning with revenue updates. The quality withhold remained the same as 1.0 in CY 2026. That's equivalent to 75 million of the total revenue. We also update that community reinvestment funding that due to our expected net surplus reach to more than 2.5%, then there is a expected community reinvestment funding that needs to be returned to the community based on the DHCS mandate. That's round up Medi-Cal. Next slide is DSNP. That's actually remained the same expectation from our preliminary budget expectations. We do expect that DSNP would turn into a little bit of more than a break-even at a small surplus level at 4.5 million, equivalent to 8.5% of the revenue. I'm going to go to the CCA as well, because these are pretty, we didn't really change the assumptions for these two lines of business. They are remain the same as what we presented back in December for the.
Can I ask you about the Cover California? Since we had that last presentation, now we're not going to get the automatic referrals. We don't know how many people can afford the increase in the premiums on that. You still feel pretty accurate, the numbers that you're projecting right now on that? So all those things are taking effect, in your plan.
We did take into consideration. This is aligned with what we are pricing for our 2026 with the with the rate increase that we put in. So we did land on initially kind of at the, pretty close to the second lowest silver plan, and now with the updated gender affirming care cost, it gets us to the second lowest cost silver plan. I think there is a lot going on in this line of business with certainly the population remain, it's going to get sicker, but majority of them are our renewal members. So there is, I think there is definitely initiatives within the plan to move risk adjustment in a way that would help us to, hit our target for our Cover California line of business. In a way, with less new members, it's easier to manage because you have your population that are renewing, they know the benefits, and sometimes with large influx of new members, it's making it more kind of unpredictable. So with this market, I think we are positive that this year, with all of change operationally as well as, on the risk adjustment operation, I think we are hopeful that we can hit this target.
That's good.
I think this is my slide.
Next slide. This is our P4P incentive budget for our providers. This remains unchanged from our incentive, from our interim budget to our final budget. Next slide. We're going to go through some G&A costs with you, and I have Vicki Johnson, my FP&A director, to present the next slides.
Good morning, board. Next slide, please. Here we have our DHCS load. What we do is we typically look at what they actually provide us on a PMPM level for our admin, for our revenue, and those type of things. So when we're looking at this here, this is only our Medi-Cal population. So when we look at this, you can look over the prior years for 23, 24, and 25, and what we anticipate to budget for 26. As you can see, our budget for 26 is a little bit higher, but also note that when we budget for our admin costs, typically they come in a little bit lower than what we expect because we do have a conservative budget. The one area that I will bring to your attention is the medical admin. That's the one on the right side. You will note that historically on the DHCS admin revenue, it came in at 8 PMPM and moved up to 9, and eventually it moved up to 14. Over the years, when we do our rate development template, we report back to the state. They've actually started noting that we do have a significant increase that was needed. So this year, they finally actually, identified that issue. So you see that we do have a significant increase. Next slide. This is a summary of our G&A and some of the areas that, were our high dollars. Overall, we're looking at about a 3% increase, which is pretty flat compared to, the volume that we're talking here. One area that we do want to make note of is we do anticipate about a 2.8% decrease in salaries and benefits. And again, this is due to the initiative for our reduction of headcount for 2026. Next slide. This slide here, the reason we actually put this in here, because our largest number that was on there was about $124 million. And it's just to give a little bit more of a breakdown on where some of that funding actually went. And as you can tell, a majority of it went through our amortization expenses, depreciation software. A lot of these things are already in place. And so these are just things that are ongoing. And as we complete large projects, then they actually move over into this area. Next slide. This slide here is actually sharing with you what our FTE equivalents are and our head count. We wanted to share with you, as Jared mentioned earlier today, we have seen some significant decreases in FTE, and this is truly through attrition. So we're kind of hoping to continue that. So as you can see at the beginning of 25, we had over 4,000 FTEs. We're hoping, or at least our target is, to have about 3,500 in that area by the end of 2026. Again, this is through natural attrition. We did look at what our rates were as far as people leaving the organization, and do we actually rehire, do we actually reorg, and those type of things. And it's doable. Okay. And the next slide, please. This is just a visual of where a majority of the FTEs actually sit within IHP right now. And as you can see, a majority of them are in health services, as where it should be. This is the frontline people. These are the ones that are actually working with our members, and they're the ones that, require the help. Next slide.
So this slide is our MSA agreements that we have.
Before we move on, I have a question.
Yes, ma'am.
Slide 12.
Yes, ma'am.
The training, recruitment, and travel seems to significant increase. I know there's so many changes going on. Is that what it's about? Because there are significant changes
Yes.
going on.
Yes. So
Okay.
one of the things that unfortunately, is part of that right there is we have a lot of face-to-face. We have a lot of our team members that are actually in the community. They're working closely with the members. They're working with our providers. A lot of that, unfortunately, travel goes, the reimbursements go up every year, but we also have a lot of initiatives out there to be more involved in the community. So we want a lot of our health services team members out in the field, actually working with our members, making sure that they are getting the care that they need.
No negative comment on that.
Okay. Any other questions?
Thank you.
Okay. And to the MSA, so these are the MSA agreements that we have with IHP Foundation and Health Access, in which they reimburse IHP for administrative services that we provide. Okay. Next slide. Do you want to do the health plan?
So we've presented this before, so I won't spend much time on it, but this is the administrative percentage of all of the local plans or sister plans. So you can see there that overall the plans have pretty good rates. Some of that, you have to understand the context of the individual plan, whether they're heavily delegated or other things that kind of make them not exactly comparable, but they're all pretty good. The San Francisco plan there would tell you that being in San Francisco puts a huge extra expense on it, certainly in the rent department. Next slide.
This is our proposed 3-year capital budget. So for 26, we're budgeting about 37 in capital investments, 37 million. Next slide.
Okay, cash on hand or COH, as we're going to now refer to it. I think you can see there that the red dotted line is the projection, so it does improve. So we're grateful for that, but we're going to work throughout the year to try to get it to go up even more, in addition to whatever level of profitability helps drive that. But there are other things we certainly are going to try to increase. Instead of the blue line, which you can see there, was a pretty significant loss over time. Next slide.
Just one quickie question on this one, on the previous one, Tim. What's your sense, just off the top of your head, as to coming back to ground zero, somewhere in the neighborhood of where we've been before? Is that a 5-year experience? What does your crystal ball say?
Well, it's a several-year process. You know, you were a very successful plan before, and I think you're headed towards that again. But the amount that you dropped in terms of reserves and other levels is going to take several years to replenish. This coming year looks to be a good first step in that, but it's not getting us back to where we were before. So it's probably going to be at least a 3-year process overall, I would say.
Appreciate it. Thank you.
All right, next slide. T&E, tangible net equity. You can see there that is it's going up, so that's a good thing. We're up basically to 440% of the statutory requirement, which you have to be because the statutory requirement, thank you, Michelle. The statutory requirement is a minimum amount. If you hit that, the state will be running your plan for you. So you can't get close to that at all. But certainly we've improved. We are 367 last month or in December, and now we're projecting to get up to 440%. So a good improvement, but we'd like to see it get up into over 600. Next slide. All right, so just a visual representation of what we were just discussing. So we basically had not much of a net margin as of December. We had 37 days cash on hand, and our T&E was 367%. One note there, and I referred to it generally, is our net margin was affected so negatively in 2024 by losing $375 million that actually tripped the first wire with the Department of Managed Care, our regulatory agency, and they put us on monthly reporting. So that isn't normal. Plans don't have to send their financial statements monthly, but they do that because they're monitoring you. That we're making progress is a good thing, and we're hoping as we go into this year and continue to add to our bottom line that they'll take us off that. But it just shows you the attention we drew by that.
A question on that. Is there a prescribed number that we're looking at for coming off of the critical list, I think you called it?
Well, they are, I'm sorry, I'm laughing because DMHC is, since it's discretionary on their part, they can choose where they decide it looks like you're going. Their goal is to make sure that if they have to intervene, they get there ahead of time, because it's too late if you're running out of money. And I might add, and this is appropriate, they're less worried about the health of the plan. What they're worried about is you run out of money, you won't pay providers, people won't get care. So they want to make sure you have the reserves necessary to ride out the quite common ups and downs you're going to see in healthcare. But it's also why the cash on hand is important, because they want to make sure we have to be able to pay people. Our level right now isn't a level that necessarily that they would be alarmed at, but it's because we were so much stronger and then lost quite a bit that we got their attention. So it wasn't just the amount. But if we dropped under 300%, we would definitely have visitors. I'll just say it that way.
Got it.
Next slide. Same issue, but this is talking about what the targets we set. And you can see there the little blue boxes are sort of where all the other public plans are, and where, or at least the majority of them are, and where we are by the red heart. So we're still below them. We are seeking to ultimately get to T&E at about 680%, which is currently the average of all the other public plans. So we think that's a good target, and as we just discussed, it'll probably take a couple of years, at least 2 to 3 years to get there, likely 3 years or more. In any case, that concludes our presentation. We'd be happy to answer any other questions you might have.
Any other questions? If not, we need to vote to accept the budget. Entertain a motion.
So moved.
A motion, and who's going to second?
I'll second it.
Thank you, Karen. Motion second. All those in favor? Aye. Lots of numbers. And it only takes the one bad quarter to make a lot of work for years to come, doesn't it? All right, just to keep on the roll, we got another PowerPoint for Quality Department. Gina.
I have no doubt.
Well, thank you for allowing us the opportunity. We're going to provide you an update on our Pay for Performance program. And I've asked Jacob Diekman, our Senior Director of Quality Systems, to share the updates for us this year. His team runs this program and monitors and provides the administrative support. So happy to welcome you all to him.
Thank you, and good morning. Good news is, I think we have the shortest number of slides, so that should be a bonus. So just to go over a little bit of background, so we've actually had a pay-per-performance program at IHP for about 27 years. It's gone quite through an evolution over the years to where now we're, very much a value-based program linked to member outcomes. And the program really does align to the sort of regulatory requirements around quality, performance, and measurement. So CMS, DHCS, the DMHC, and NCQA all have quality measure requirements that they hold the plan to, and our current incentive programs all align to that. And our pay-per-performance programs are really one of the primary quality improvement sort of drivers to maintain that quality performance. Really linked to, providers providing care. That's really, what we want to see, and that's where, these quality metrics, come from, is actually, members getting the care that they need and deserve. So if we move to the next slide. Jared touched on this a little bit around sort of the new requirements that CMS has laid out, specifically around incentive programs. So beginning in calendar year 2026, CMS has required that an actual contract amendment be signed prior to the start of the measurement period. And part of that requirement requires that we have a clearly outlined, measurable sort of document so providers know sort of what is required, as well as a target dollar amount so they know sort of if they sort of max out in the incentive program, what could their, final dollar amount be. So we worked with our contracting team and our provider experience team, through the third and fourth quarters of last year to get 699 out of our 702 contract amendments signed, so covering about 32,000 providers with a 99.6 completion rate. We only had the 3 providers opt not to participate, so we were pleased with that. So if we move to the next slide.
That's a real accomplishment right there.
Yes. It was a lot of hands on deck, especially because it all had to be done before the end of the year. And with the holidays and, everything, with people being out, provider offices as well. Just a lot of work amongst all the teams at IHP to make that happen. So if we move to the next slide. This is just an illustration of some of the measures that are part of the program. It's not an exhaustive list, but these are some of the more common measures we see across all the regulatory requirements. And so you can see sort of in summary, sort of in aggregate, it's about an 88% improvement, about a 7.4% increase per measure. So very strong performance in this measure set. And as part of the P4P program, we have a lot of programmatic supports to help providers to reach their goals. So if we move to the next slide. Just a quick overview of the budget for the incentive programs. This is included in the budget that the finance team just presented. So this is already included. So you'll see just over the past 3 years, in 2025, we did implement a pretty significant cut to the program, just in response to the financial situation the plan was going through. We've kept the budget stable in 2026 in leaving those cuts in place. And then if we move to the last slide. So what is the path forward as we continue to leverage this program? So we continue to work with providers on data quality, improvements, proper submission, proper coding, making sure they bill for all the services that they are delivering in a capitated environment, that making sure you're billing or submitting the encounter for all the services is key. For provider tools and resources, we do produce for providers gaps in care rosters for every measure so they know what members are due for the service, which members have completed the service to help, as they bring members in to make sure they're not missing any services that are required. We also do provide them on a bi-week or twice a month basis their own individual sort of report card, if you will, that shows them how they're doing within each measure, their potential, payment at that moment in time, also so they can keep track of their progress throughout the year. And then just lastly, with member engagement, it's really a complement to the program overall. you know, the program sort of supports the providers, but we actually have to get the members into care. So we do a lot of work, you know, ensuring members know what services are required, how they can get care, encouraging them to call their PCPs and make that appointment. And I think that's it for me. Any questions?
Just curious, how did the providers respond to the last year's budget with the big cut we had?
It's rough. Anytime we make any change to the program, we do get a lot of feedback. So we did take a lot of that feedback internally. They're never happy when it's a reduction. But what we tried to do is sort of take some of their feedback around certain measures that we had removed. So we removed a significant number of measures from the program in response to, you know, the lower dollar amount. We thought that was sort of a fair sort of trade. Not necessarily from their perspective, because some of the measures we took out, you know, they were really passionate about and thought they were important to keep. So we reintroduced those in 2026 to sort of round that out, but still maintain the budget.
It always interests me. This is what they should be doing anyway.
Yes.
You shouldn't have to be paid for doing your job, but.
Right. But it does, you know, what we've heard, it does sort of help support the infrastructure, and, you know, and investments they make within their practice to make sure they're able to do all these things. Anything else?
No, any other questions? Thank you.
All right. Thank you very much.
Thank you, Jacob. I have one more item on the next slide. And you can go for one more. So this presentation is bringing to the board a little bit earlier than usual. This is our Quality Achievement Program, which is essentially the team member incentive program that's linked to our quality outcomes. This is the 4th year of this program that I'm introducing here to you today, that we're going to be asking the board for approval of. What's different is that we're bringing this program to you here in February instead of typically in July or August. In the past, we waited until our final performance was clear to set the targets. What we've learned from the teams who are engaging in this work, they've asked us to really tell them about these measures and our targets earlier in the year so that they have more time to impact performance. And so we're happy to respond to that ask, and that's why I'm here a little bit early this time, asking you for approval of this 2026-2027 program. Essentially, what we'll be doing is setting a program in place for performance year 2026. Team members that would be eligible would be hired at IHP before October 1st of this year and employed on June 30th of 2027 next year. The structure is essentially the same as our prior years, where we have this tier value opportunity by team member status. So for directors and above, that maximum earning potential is 15%, and it goes through the different levels that you can see there on the screen. The payout and the calculations align to just the quality payment cycle of what we report to the state on an annual basis. And so the payout would be planned for July of 2027. Next slide. Again, the structure is the same, so this slide should look pretty familiar to you. We have 10 measures in the program, each carrying the same weight. We've defined 2 distinct goals per measure, an improvement goal and an achievement goal. And essentially the way that we structure this is it's continuing to challenge us as an organization to continue to improve to that next level of benchmarks that's set by the state and by our national kind of thresholds. And so looking to see how can we continue to strive for improvement. Next slide. This here just shows you the nice outline of the measures in the program and which regulatory agency uses it in their monitoring of our performance at the plan. So you can see there's really good alignment, that these are measures that are important to our regulatory agencies. Next slide. We also heard you last time when we came forward that it was important to keep the measure set stable, so we are not changing any measures. But this here is just the illustration of the targets and how this will work. Again, we're in the interim performance period, so I don't have final 2025 performance rates yet, but we'll follow the same methodology to set the final targets in July once everything is final for 25. But we'll see where we land as far as a national benchmark to then set our improvement and achievement goals. And so the board will see with transparency in our reporting back to you how we're progressing throughout the year. Next slide. And just an update for our 25-26 program that's still active and underway. We've been sharing these results with you monthly as well in your board packet, but we have been making some good progress. Out of the 10 measures, we have met essentially 8 out of the 20 goals that's set there. You can see 4 measures. We've met both the improvement and the achievement goal at this time. We do expect more data to come in, so we do continue to expect rates to improve before we finalize in June. Next slide. So the official request here is for the board to approve this program. Again, the eligibility, as I mentioned earlier, and the values set, again, the same as the prior year with this consistent payout timeframes in July of next year. We are estimating that the payout would be approximately $15.6 million. That would be in
Does
July.
that get everybody, I mean, if everything goes through,
No, that's.
so what is the maximum? Not
the max?
Yeah.
I don't have that number.
That's good.
But that is what we're highly likely to hit.
I understand
But
likely.
we can get the max payout. I don't think I have that. Yeah.
Well, if you're calculating 15.6, that's based on approximately what percentage of completion?
Fair, half.
Yeah, so it could be up as much as 30 to 35 million.
That could be, yes.
And that's what it's been in the past as well. Jared, do we see any other plans doing this, by the way?
Yes, we do.
When we started, it was fairly unique, but
Yeah, do you know, Jania, how many, excuse me, how many plans approximately are doing this?
I think it's just a handful, not across the board. I think not as maybe detailed as this one is, but it is common. But I think ours is pretty robust as far as the structure.
yeah.
So can you hear me? So I'm kind of trying to soak this in. So is this basically 15% to the CEO and all the directors, 10% to the managers, 8% supervisors, 5% to team members? Is this what they're
It's
getting? or is-
performance-based, so only if we hit all of the targets, that would be the maximum earning potential, yes.
So your boots on the ground are only getting 5% and your CEO is getting 15%. I'm trying to understand that when the pay differences are enormous.
And I will go back a little bit in context because we did this prior to your appointment on this board. We were looking at a way to, we get graded by all these other agencies, how well we're doing these different things. And there's only so much we can do internally versus externally because their providers are kind of on their own. Hence why we had the big budget to pay doctors to do things they should be doing as well. But what it takes is more of the management level to change the priorities internally. And we wanted to figure out, not just give out money each year for no reason for bonuses or for other things, but actually have it linked to our performance, how the health plan was being graded, I guess, as a whole.
I mean, are we as a organization underpaid? Or where do we sit? Because in my mind, when I'm seeing this, we all get paid to do a job. There's an expectation of what your job is. You should be doing that job without a bonus. I can see if you're underpaid and you're going for a bonus, it gives you some. But if you're right there at par, if you're not doing your job, then you get replaced usually. I mean, I would be replaced. If I don't do my job, I'm getting replaced. I'm not getting a bonus. So I'm just trying to understand this whole incentive of $15 million.
It's, instead of going across the board like we do, when we do, hey, you got a cost of living at 3% or whatever the case may be, and how do you do that for a performing department more so than the other department? So we based it connected with our performance goals. And so those departments that are affected or do extraordinarily well are getting rewarded at a higher level. And yeah, the boots on the ground, they only get 5%, but there's a lot more boots than they are than one CEO. So the actual bigger numbers are going to the ones in each department. And I'm hoping I explained it correctly, because that was part of my concept when we did this 5 years ago, or whatever it was.
Yeah, relative to our sister plan, LA Care, their bonus potential for the CO is 50%. So ours is much lower than that. And when you compare Supriya, I don't know if you have data on the other plans, but we looked at every plan's structure on incentive comp. And this is actually incredibly in line with all of that. So I don't know, Supriya, if you wanted to share any comments on that.
Well, you're coming up too. I think the other thing that we were looking at is something that impacted everybody about something that was really important to us, meaning quality and outcomes. And we wanted to make sure that it was our members that wound up benefiting from this and not incentives regarding other things. So this seemed very aligned with what we're about.
I think one more thing to add too is that these are stretch goals. These are not easy to achieve. These do require kind of all levels to lean in, including providers, to get there. So these are hard to reach targets that continually move up from year to year. So
And you never have reached all of them.
right.
No.
Yeah. Good morning, everyone. Just to share a little bit more, yes, the other sister plans do have incentive programs. CalOptima has its own, as does LA Care. They're not necessarily all tied to just quality. They have different components. We also tend to hire a lot of our individuals from outside of our sister plans, so that includes companies like Molina, Anthem, Elevance, United, et cetera. And this is very common, and we're actually at the lower end of bonus programs when you can compare it to for-profit, but that's not what we're looking at. I think as some of you who are on the comp committee know that we look at the for-profits, but we tend to push it on the side and focus on the sister plans. As Jania mentioned, as did Supervisor Hagman, that this is very related to performance of quality. So the more revenue we can generate, this allows us to give out the money. So it's not an admin cost, which is in addition to everything else in the budget. Only when we get the revenues in, because we are performing on quality, are we able to give the money out. So it kind of incentivizes the performance to be able to pay out. And as mentioned, we haven't hit the total percentage, not from the time I've been here, which was 2023. Tends to be about half of it each year, and they are stretch goals.
I know where you're coming from, because I had a hard time when I first got this. It is very hard to say, do the job, but we're saying, do the job, but push harder. So this is the incentive for them to go above and beyond mediocrity. Just go harder, and in the process, it's meeting our needs as an agency with our partners and those that had their thumb on us, because then we are doing better as an agency. But if you just sit here and pay the salary without an incentive, then that's what you're going to get. You're going to get work that's not going to be as robust unless there's that incentive. All of us work for incentive. Whether it's praise or financial, there is a reason we sometimes work harder. We work harder because we want to get reelected.
Well,
right? Hey.
I come from the private sector, and
Well, so do I.
And for me, it's like,
No.
if I don't work hard, I don't make money. That's just it. I mean, it's my fees, my fee.
Yeah, but if you don't do well, you're not going to have somebody else pay that fee.
This is not my money. This is something I can't absorb right now. I'll just be quite frank. I would ask for this to be tabled and maybe give you guys an opportunity to explain this a little bit better, because what I see right here is waste. I'm just being honest. And I don't think, I want to say, help me understand it better. And I would ask if we could table this to another meeting. Maybe I can get with Jared, and Jared can kind of give me some real data numbers, comparisons, and show me why this is so important to this organization so that I can support it. Because right now I really can't.
Is this time critical?
Janine, what are we under on time for reporting this back to the?
So we are looking to get, obviously, this launched sooner rather than later to help just get the momentum and the energy for 2026 performance, because the clock is already ticking. But we do have a time if we need an extra month to kind of do that extra deep dive. We can do that.
Okay.
So we got a budget in the budget anyway, we just have to act on it. So, yeah, to give my colleague a little more time to get the.
We can absolutely do that.
together
Bring
that
comparative
and
data.
such. So
Absolutely, yes.
We'll table it till the next meeting then? Do I need a motion on that, Anna, or? Yeah. Jesse moves to table it to the next IHP regular board meeting. Entertain a second on that.
I'll second.
In a second.
I told him to speak up, but not about this item.
Okay, all those in favor? Aye. Thank you. That is the last agenda item. We do get to go to closed session, and we have 2 items scheduled for a closed session. We anticipate a reportable action, which will be announced to the public once our discussions conclude. And can you please read the matters into the record?
Be happy to, sir. The first one, conference with legal counsel, anticipated litigation, initiation of litigation pursuant to subdivision D4 of Government Code Section 54956.9 for potential matters. The second item, with respect to every item of business to be discussed in closed session pursuant to California Government Code Section 54956.87 subdivision B, a meeting for purposes of discussing or taking action on health plan trade secrets.
Sounds good. So we'll adjourn the closed session.
Did you get it? You have this? Raphael will turn it on.
Okay, we're back from closed session, and I think, is Anna going to read it out, or Annette? Right?
Mr. Chair, I'll report it.
Okay.
For closed session item A1, after conferring with counsel, the board took reportable action to authorize the initiation of litigation in all 4 potential matters and delegated authority to the CEO or his designee to retain outside counsel. This action was taken upon a motion by Chair Hagman and seconded by Member Zorn and approved with all members present with no abstentions or recusals and no opposition. The actions, defendants, respondents, and other particulars are not disclosable at this time until the actions are formally commenced, unless to do so would jeopardize IHP's ability to effectuate service of process on one or more parties or would jeopardize its ability to conclude existing settlement negotiations to its advantage. That concludes the report out.
Thank you,
Mr. Chair.
Ray. We're going to go back to adjourn back to closed session, but we don't expect any reportable items on number B. So we'll adjourn the regular meeting to closed session for the day. Thank you.
Thank you.